Today is a very hot topic, we can tell. Other than the job offers, internship and what you can do after BPT, we took many topics, be it in professional issues or it is in professional development. And today's topic is a most important topic, specifically because our own team, the AYMPT team also, many of us, they are doing the MPT, they've given the exams, they have been toppers in their institutes, and there are still people who are giving the MPT exams. So I never see in terms of one person is giving the exam, so I will give my inputs to that person. I always feel that when I am giving the inputs, those inputs will be useful for everybody. So even if a AYMPT member is contacting me for a case query, they have a question related to a patient, even then I say that how many minutes you need from me, and if they tell that I need half an hour, then I tell them that better ask me on Zoom or sharing the screen in Instagram or in Facebook, because it's not a discussion between two people. We know that these discussions will help a larger community. Of course, when we are talking about MPT and preparing for the Master of Physical Therapy MPT, which is like an entrance exam or it is a university exams. Remember, this MPT terminology has been erased out of the world. Many countries are not offering the MPT degree. Some of them which are really advanced, like US and Canada, they are offering the Doctor of Physical Therapy. Whereas if you see, they may give a transitional Doctor of Physical Therapy, which is for the shortened version of Doctor of Physical Therapy for people who have already done the BPT or their credentials are sufficient enough that already they have a undergraduate program level credits. So it's always when we see this situation that entrance exams, of course maximum confusion comes in candidates to choose which college I can choose for MPT, and I have addressed that in the MPT related issues in the professional issues webinar previously, how to choose a good college, what you should give value. To summarize and bring it as the bottom line, which college you will choose for MPT is the college where you actually have the best teachers. Best teachers in the sense, they are not the best because of their high level of qualification. They are best because they are sincere enough to share their knowledge with you. I have given a request to Dr. Darshana to add a join on the screen. I am just waiting for Madam to join also. She is the inspiration for today's webinar. Okay. So, why? Because the basic difference between a BPT and an MPT, other than the abbreviation what you are writing in the nameplate or the board, and I have also highlighted in the previous webinar that MPT is for teaching profession. For practice, yes, Dr. Darshana.
Hello, sir. Good evening.
Yes, welcome. And you would want to raise some points. You want to raise some points and you want to create the ignition, the fire of MPT exams.
Yes, definitely.
What is the things which you feel
Definitely,
which is very, very untouched area in preparing for MPT exam?
Yes, sir. So I think yes, today's webinar is very, very special for me because I am one of the candidate from AOMPT to be attending the MPT exams.
So on behalf of the academy, we wish you the best of luck. And
Thank you.
in fact, the best of your destiny is waiting actually for you. Okay. So it is just a milestone. And your graduation is going to inspire many people further. And it is going to give you a better professional identity when you are having further
Yes,
milestones, okay, ahead in your life. Yes,
absolutely.
Darshana, tell
Yes.
me.
For me, doing MPT is like a dream come true. I'm just waiting for the exams to get over and, of course, have the degree in hand and feel more empowered. Okay, so I have a few queries in my mind because I have been, I wouldn't say very regular in my studies for the last 2 years, but yes, I have started picking up pace now for the studies. So if I see from my perspective, the topics are very much similar to what we have learned in the BPT. Okay, but as we definitely know, it has to be a very elaborated thing, a same topic but in a very elaborated fashion. And another I think another obstacle what everybody would be facing is studying from various books. There are so many books, so how do we tackle that, like uh, I mean, there are four papers, five papers rather, paper one, paper two, paper three, paper four, and every paper has different topics, right? But every time now and then I receive PDF of so many books. It's practically impossible to read so many books. So how do we go about it? So that would be my first query to you.
Okay. Example of a topic.
Okay. For example, I would take something like biomechanics. Okay, or gait
Okay.
analysis for that matter.
Okay. So you want about normal and pathological gait, hmm? The mechanics and its pathomechanics. Okay. So this is what I am telling is it depends also on the topic. Okay. For some topics, some
Okay.
textbooks are good. I am not coming to textbooks. I will not advise you to study textbooks only. First and foremost,
Right.
search for journal articles. So in the
Okay.
journal articles, there are different types of articles like review articles. So those review articles you should specifically search. In Google when you are putting search
Okay.
or in PubMed Central, because PubMed
Mm-hmm.
Central gives full text of journal articles. So in that you can put
Yes.
gait, stance, swing, all these search terms, so that you will get
Mm-hmm.
articles which is full text content which is free. And these articles are
Yes.
preferably, you will see that after 2020 also they'll be there, very recent. And in your
Right.
answer sheet, when you are putting references, a journal article, always it is going to give an added weightage in your PG exams. Okay. So
Right.
instead of memorizing content from 5 different textbooks, where first you want to learn from Cynthia Narkins, then you want to learn with what is called as any of the clinical orthopedic textbooks, which is describing about abnormal gait patterns and injuries. Okay. Rather than that,
Hmm.
directly going for an article which is a review article, it is hardly 5 6 pages, and the author would have already compiled from many textbooks, many journal articles before,
Right.
so it will actually solve the issue majority of the time. Okay. Um,
Right.
if you are searching
Right.
in Google, you will put the term review and then you will search. Okay, review of normal gait, pathological gait, or human walking, human
Hmm.
locomotion, review. Okay, so these
Okay.
kind of terms when you put
Right.
and search, that PDFs which comes immediately,
Hmm.
definitely you will be getting more idea into. And what you need to do when you are also preparing, for example, this is one topic. You might have 20 topics or sum of 50 topics. If it's a major subject, means 50 topics will be there. Basic science subject like
Yes.
biomechanics or examination or functional diagnosis, it will have only 25 topics, major
Yes.
topics, which are detailed questions. Okay. So the detailed questions is the primary priority. Okay. And the evaluation of MPT paper, the proficiency, the topper, especially is decided by the detailed question in the theory exams in MPT.
Okay.
In BPT, it can be the how organized your paper is, how neatly it is presented, what are the diagrams, what are the flow chart and table, and lot of issues there. Okay.
Right.
So you can think of these 20 topics, collect one review article for each of this, and then from that review article, you have got the information which you have to write for the exam. Okay, like around 50% at least you can cover from that article. Other than that, you see for
Right.
the major references. For example, if your core specialty is orthopedic, I would suggest that there are a list of 5 textbooks which are actually better for an orthopedic level. The best example of such a textbook is Management of Common Musculoskeletal Disorders by Randolph Hertling and Darlene Hertling and Randolph Kessler. Okay, Hertling and Kessler.
Okay.
This is a textbook of all soft tissue injuries, and every region is given with anatomy, biomechanics, examination, conditions which are in that region, like shoulder. Okay, and for each condition, what is the special test and treatment manual techniques with exercises, all are explained. The book almost is around maybe 1,300 pages, something it is. Okay, so it's a very big book. E-books, it's fine. But this book is a very, I can say, PT orthopedics. If you have at master's level, means don't read any book other than reading this Hertling and Kessler. Okay. Second thing is, when it comes to gait, like, and also we have another textbook of orthopedic physical examination, orthopedic physical therapy, Roberto Donatelli. Okay. Roberto Donatelli.
Yes.
Donatelli. Okay. So it is Donatelli's textbook of orthopedic physical therapy. Okay. So this is also, it gives about gait itself. It gives every segment and even subtalar joint mechanics also between forefoot, midfoot, hindfoot. So it gives a perfect explanation. Okay. The osteokinetic chain between hip knee ankle interaction also. So this textbook also gives regional examination, regional treatments, but it is 1/4 of the size of Hertling Kessler. Okay, so these both books are for regional conditions. Okay, like all the soft tissue injuries, examination, including their anatomy, mechanics, and exam, physical differential diagnosis, everything. Okay, so Robert Donatelli, the orthopedic physical therapy, and you have this Hertling and Kessler, management of common musculoskeletal disorders. So if I am an orthopedic examiner and I am correcting, definitely I will expect that the content is from these two texts. Okay. Maybe the syllabus or the RGUHS, they might have given this under the references. Okay. Suggested reading. Okay. Or they may not have given also. That is another thing. Okay. So that is about the curriculum committee, what they are doing. Next thing, if you see, if you are talking of the conditions like congenital conditions, metabolic conditions, you have osteoporosis, you have rheumatoid arthritis. Okay, those conditions are there. And in that orthopedic perspective, you have to write. And in that, including investigations, including the pathophysiology of the disorder, these and all you want to write. Okay, so that is, there is a textbook called as Turex Orthopedics. Okay, So that
Yes.
actually gives TUREK. Okay, Turex Orthopedics, textbook of orthopedics. It's again a bigger book. All these books are reference text. Okay, they are not actually for exam preparation. What do you mean by reference text? That means you have a patient of rheumatoid arthritis. You want to communicate with the orthopedician, the surgeon. Before that, you can just look at this book and then go to that surgeon to discuss. Okay, if it is a clinical ortho textbook,
Right.
or if it is this Kessler and Hertling also. If a patient has come, you have done today, you have seen the patient, but evening when you come back to your room, you feel like I should do something extra. Okay, so just go through this, what is given, have I done everything or not, and anything extra is there, and then explore and go to the next day. Of course, your situation is different. You have AOMPT courses and videos for every condition. That is clinical practice wise, you don't have a
Absolutely.
query. All you need is only the theoretical
Yes.
one. So that is why journal article, review article
Correct.
is the foundation. Above that, you add the content from these textbooks. Also, if it is from
Right.
fractures, in ortho, clinical cold conditions are there. Cold orthopedics means this what is called as all this rheumatoid arthritis, osteoporosis, osteomyelitis, septic arthritis, TB spine, okay, congenital talus
Yes.
equinovarus, all these are there. That is Turex orthopedics. And if you see for soft tissue injuries, we have already seen Robert Donatelli and Hertling and Kessler. And the same way when you go for
Yes.
here fracture dislocations, there you have Stanley Hoppenfield's treatment and rehabilitation of fractures.
Open.
Okay, so
Yeah.
that is also one standard textbook. It is the only exception. It is a small textbook, but it has good content for master's level. Okay, because in post fracture, if you are a master student and you are approaching a rehab post fracture after internal fixation, then definitely you are going to talk about only concept of management. Okay, if protocol wise, if it comes,
Right.
you always know that this you should also frame what is called as the concept, how I am going to approach a cold orthopedic condition, how I am going to approach a PT management condition, how I am going to approach a rehabilitation protocol. Okay, so for example, PT management for shoulder impingement syndrome. So how I am going to approach that if a question comes like that, or if a question comes in terms of scoliosis, okay, it's a cold orthopedic. So then how I am going to approach that, and the same way rehabilitation protocol following Harrington rod fixation for scoliosis. Okay, so that comes.
Right.
So moment protocol comes, you should know that how many days, how many weeks, phase wise how we are progressing. Okay, most of the things are pre-operative period. First is pre-operative period. Every post-operative rehab answers. Okay, but if the question is very simple like laminectomy, or it is like THR, TKR, total knee replacement, total hip replacement. These are the major rehabilitation protocols, okay, which usually comes, or ACL injury,
Yes.
reconstruction surgeries, and you also have shoulder, no, elbow, hand, yeah, hand crush injury, plastic surgery, burns, okay, rehabilitation of burns in the hand protocol can come, or amputation and prosthetic rehabilitation. Okay, so rehabilitation protocol can come. So these are the major things. However, burns and amputation are the general surgery aspects, but they do come in ortho because it is a part of the
Yes.
goals, the treatment goals that we have for mobility, functional training, SCAR, and everything. So you decide that pre-operative, yes. Next one, for example, a THR, it's an articular surgery. If it is a implant internal fixation for a bone, That is bone surgery. If it is like tendon transfer, it's a soft tissue surgery. Okay. So you know what is the healing period for the soft tissue. Soft tissue healing 3 weeks.
Right.
Bone healing 6 weeks. Minimum 6 weeks. Upper limb 3 weeks.
Yes.
Okay. You can say X-ray the callus is forming, but you cannot what is called as do passive mobilization until 6 weeks. Third week maybe you can start active. Okay, active assisted like that. This is upper limb. Lower limb, if you see, you have 6 weeks to 3 weeks, 3 months. Okay, the 12 weeks. And spine, essentially after 3 months only. Till then, we are not going to do anything with the spine. Okay, anything to do with movements. Same with surgery. When it comes to decompressive surgery in the spine is there, and stabilization surgery is there. So try to classify the surgeries.
Right.
Decompression means it takes a longer time to mobilize.
Okay.
Because we are just removing the discectomy, carpectomy, laminectomy, all this, facetectomy, like that. So it is actually that segment is removed, but it is not actually strong. Okay, it needs time to heal. But if you see stabilization, they are essentially fixed with wire or rod and fixed. So these patients are earlier mobilized. Okay. So without surgery once, it will be delayed till 3 months. So non-operative 3 months.
Right.
So if it 3 months only, then only the immobilization phase is 3 months. Okay. That is how the spinal fracture goes. If the same way, if you are going into, then further is, if it is only non-operative management, you have to explain the condition more. For example, anterior instability of the shoulder. That means you have to explain about all that structures for stability, what are all the types of instability, then types of anterior instability, special test, everything you can explain because this is a detailed question. Okay, but start with the instability only and move on like that. When you are seeing for a post-operative management for shoulder instability means, you know that it is only the Bancart's repair, and after that you see for the maybe the arthroscopic repair for the labrum or the minor surgeries, whichever we do inside the shoulder, or you see for the laser or the electrothermally assisted capsulorrhaphy. Okay, so these kind of things, the rare things, whether you remember or not remember, that is only the final what is called the cherry on the cake. Okay, if you can remember one or two. Shoulder, what are the recent things? What are the catchy procedures, surgery? Okay, so like that. And elbow means what are the things? Lateral epicondylalgia, what is the thing which is very catchy? Okay, something new. So in that you know that in AOMPT, a lot of techniques, everything is a new one only. Okay, you can always describe fasciomuscular release techniques for any region. Okay, scar is there post-operative, so you can answer. So it always goes like that. Motor control, functional, in that functional neuromuscular stability training, the motor control is actually the early phase. So early phase it can come after spinal surgery also. Late phase, recovery phase, return to activity phase, then you can put the functional training. Okay, so you can go as per the problem based approach. Okay, and in MPT rehab protocol, even if you are mentioning like first 1 week, 10 days, it is always about the scar, suture site, that wound drain. 10th day only suture removal. Okay, 1 week to 10 days only suture removal. Before that, that locally area scar treatment, nothing there. Okay, so all that which we do is only the bedside, active movements, preventing complications. So post-operatively only this much comes. Okay, and respiration and then strengthening the upper limb or the other regions to strengthen. And functional, assisted mobilizations, all these things. So after the suture removal, then you are going for what is called as the movements. Okay, in that region where the operated region, then movement comes. That is the recovery phase. And
Yeah.
the what is called as early post-operative phase or the protective phase. Okay, and then the recovery phase and return to activity phase. If recovery is not there, it is the actual what is called as the rehabilitative phase. That is like we are not expecting people to become totally normal, but at least we want that functional training to be incorporated so that as much as possible the patient can
Right.
get into independence. Okay. So what we need to do is if you are having all the regions, so hip joint, definitely hip replacement only detail. Otherwise, fracture neck of femur. So these two conditions. So knee
Yes.
means osteoarthritis knee, patellofemoral pain syndrome, total knee replacement. Okay, or ACL reconstruction.
Hmm.
Okay, so these four. Ankle means lateral ankle sprain, maybe plantar fasciitis if the examiner is such a very trendy examiner. And then CTEV, the congenital talus equinovarus. So more
Hmm.
than that, you are not expecting anything big out of the lower limb. And if you see lumbar spine also,
Right.
sacroiliac, either ankylosing spondylitis for sacroiliac, if you have to see for detailed question related to sacroiliac. If it is the recent advances aspect, sacroiliac dysfunctions or sacroiliac pain, it can come. Okay. So that anyway, you are well versed with the pelvic specialist you are. Okay. So the next one goes to in the cervical and lumbar, there are list of conditions. It can be radiculopathy, which is usually the prime focus because all radiculopathies involve back pain or neck pain with the upper extremity pain, with the lower extremity pain. The radiculopathy can cause
Yeah.
stenosis. Radiculopathy can come as bilateral, then cardiac venous syndrome, all this. So
Yes.
radiculopathy always is the first priority for detailed questions. A spondylosis, nobody will ask as the detailed question. So you
Okay.
can think of these kind of probabilities. Okay, what is the big content? So where you would like to emphasize.
Perfect.
And when it comes to shoulder, three conditions as instability, impingement, and frozen shoulder.
Hmm.
So after that comes to
Yes.
elbow, which is only lateral epicardialalgia, otherwise supracondylar fracture
Hmm.
in children. Okay,
Okay.
and wrist Colles fracture
Right.
and the crush injury, hand burns or crush injury or tendon reconstructions. Okay, this is hand. I don't think a
Hmm.
rheumatoid hand or a leprosy hand, if it is going to come anywhere. Okay, so but that keep that option also. Okay, in just to add on with additional points, the rheumatoid deformities of the
Hmm.
hand, and also leprosy is the
Yes.
neural nerve damage related deformities in the hand, the splinting,
Yeah.
how the sensory re-education. So these kind of emphasis. Okay, when it
Hmm.
comes to RA means energy conservation, that added points. That means the core structure of your answer,
Ah.
you should see that what could be the subheadings if it is a post-operative. Okay, and I am going to talk with indications for surgery. I am going to talk about
Hmm.
the methods of surgery. Okay, how what approaches can be done, what prosthesis can be done for a replacement, and then I go to the phases of rehab, which is like pre-operative, then immediate post-operative, then we go to the progression, and then till the return to activity. Okay, and in every phase, make sure that for the scar, form, range of motion, strength, gait, and functional training. put subheadings. Okay.
Yes.
So what it happens is you are having a problem list. So patients can have pain. So that pain, why it will be there? 3 months after the surgery, why the pain will be there? Because of tightness, adaptive shortening, joint stiffness.
Yes.
Okay, so those kind of issues. So the same way, 6 months after surgery, pain is there. That means you should suspect that something kind of a implant failure. Okay, you are not expecting pain after 6 months. Okay, after a surgery. So radiological check is required. Okay, to see whether infection in the implant or in the prosthesis it is there. Okay, so mention in terms of like if somebody is thinking like I am operated 3-4 months, I look at the 4th month. That itself I should be able to treat that 4 months post-operative patient. In that additional complications are there. That means knows that the patient is a complicated type. Okay, not the typical type of progression. So, and this orthopedic conditions, the textbooks, yes, fractures. Physical examination, if you want to know like special tests and all that, please don't read David Maggie. It is impractical to actually read that David Maggie. Kessler itself gives examination. Donatelli also gives examination. So they are absolutely fine, these two. Okay. Right. So this is an example. Same way for cardio.
Right.
There is a textbook called as Fundamentals of Respiratory Care. Egan's Fundamentals of Respiratory Care. It's a very, very useful textbook. Okay. And then you have cardiopulmonary rehabilitation. There are various textbooks which are compiled, including by Elizabeth Dean, which is evidence-based physical therapy in cardiac rehab, cardiopulmonary rehab, something. And when you are seeing for what is called as the neurological, Darcy Umfred, neurological rehabilitation is there. It's a very big book, which actually gives a very comprehensive picture. Other than that is physical rehabilitation by Susan Sullivan is more than sufficient. And for spinal cord injury alone, you see Ida Bromley, paraplegia, tetraplegia. There's a textbook, small one. And more than this, what I would say is foundation is anyway in your articles. So when you have prepared that what is called as the common detail question and then articles, it will solve a big picture. Okay, first thing. That is the block. Okay. Because if you are sitting with textbooks, there is no starting, there is no ending. And ultimately you will feel like, you know, yeah, okay. So make sure that to get through with that.
Perfect.
Other specialties like women's health, in sometimes pediatrics is also there. So a lot of, they all have good textbooks, standard advanced ones, which is a compilation of many books, and they are written by international authors. Okay. It must be there, but the faculty don't expect the students to read from one textbook. Okay. So the faculty will not tell that read this textbook. Okay. They won't tell that. At the same time, your responsibility is, if it's a fracture question means, okay, these references should be there. So make some list of 5 references for fracture. Yeah, I forgot to tell about THR, TKR, rehabilitation protocol, anything. Brent Broadsman, textbook of orthopedic rehabilitation is there. So the Brent Broadsman textbook is actually good for THR, TKR. When I have conducted the fracture rehabilitation itself, I referred from the Brent Broadsman also. Okay. Shoulder instabilities, Bankart's repair, sports related surgery, soft tissue. labral tear, repair, arthroscopic repair, after that rehab. Even if you don't remember week-wise, day-wise, what is given in the textbook also, at least after your answer, you have to write the textbook as a reference. Okay? Because it is, we cannot follow date-wise. Clinical practice is not like that. Okay? So it is only a guideline. It's only an example.
Yes.
So that way we can approach. And examiner will be happy to see these references being listed in the answer itself. Because they want to see first impression in a PG theory paper, what they want to see. It should be more organized. That means not big paragraph. Okay? Lengthy paragraph, if it is continuing means the same paragraph is continuing next page also. Some people write like that. Okay? So that is not at all impressive. When you put subheadings as much as possible and make your questions to be organized, and even if you have described phase-wise in paragraphs, okay, preoperative period in a paragraph, immediate postoperative period in another paragraph, whichever you are describing, still you put another table highlighting the same points. So that table rehabilitation protocol means the table should be there. Okay? Don't think that only the text paragraph alone will suffice. So you need a table there, so that will create that actual impression of protocol. Okay?
Perfect. Yes. Very nice. Very nicely explained, sir. I am feeling so. Yeah. So this was more, we talked about the musculoskeletal aspect. I think another main obstacle from the theoretical point of view, if we see, is the exercise physiology and the research, the actual theory part of it. Like, of course, when we do our dissertation, we cover mainly all the aspects of research. We know how to, we know what is the pro forma and everything. But when it comes to actually practical writing, how should we study about it, and how should we go about both the things? Like, one is physiology, exercise physiology, and one is the research thing.
If, for example, I forgot to tell about the sports, there is a textbook, David C. Reed, REID, Sports Injury Assessment and Rehabilitation. Okay, that is again a comprehensive book. Multiple regions, multiple sport-specific injuries, everything. Okay, in one textbook it is covered. Other than, of course, journals which will be there for sports, lot of athletic training journal and all, they give full text. In exercise physiology, of course, there is a what is called as overlap with sports and conditioning. If you are seeing for journals like medicine and science in sports and exercise, okay, medicine and science in sports and exercise, okay, or you are talking of Journal of Applied Physiology. Many journals are like this, which are actually providing PDF free content, and they also have review articles. Okay, so these kind of things, if for example in this exercise physiology also, the question will be like more of an example. Okay, so what could be the it will not be a systemic effects, it will not be like a disease, it will be more like a health and wellness prescription. Okay, so how we are going to understand the effects in that particular patient, okay, and how we are going to individualize the exercise program, and what are the considerations which you use it to apply in the decision making. What I would also suggest parallelly is previous year's question papers. If you need to know what extent which topics have been emphasized previously, okay, no examiner sets the question paper without seeing the previous year's question paper. Okay, Every examiner gets that previous year one question paper as one format. Okay, so then you have to keep the questions like that. So same way, um, the last year question paper, the recent one, whichever came, mostly that will not get repeated. Okay. So if there is a detailed question which was asked in, if I am giving now in March, so if it had come in October, okay, or November, that means that October, November paper will never be repeated in the March. Okay. So I don't have to read those topics unless I have extra option in the end that I can read those topics. Okay. Optionally, I can keep it and then go for the other ones, which are the what is called as the probable questions. Okay. If, for example,
Right.
if it is to do with hypertension or diabetes, or is it to do with exercise training, anaerobic exercise, resistance exercise, the effects on various systems? Okay, it can come, or it can come as exercise in the elderly, exercise in the pediatric population. Okay, so it can come in any way. So remember that in that also, you know that there is a basic differences related to that system where the disease is. Okay, if the disease is a renal, disease is a hormonal, okay, disease is, for example, a metabolic like obesity. So where is the thing which is majorly affected? Okay, so that's cardiac rehab also exercise prescription is there. So in every aspect you can think of, and you need to modify only that system. Okay, if it's a cardiac disorder means cardiac changes to exercise will not be actually adapting that faster. Okay, and it has to be monitored with non-cardiac parameters. Okay, so I cannot monitor a heart rate. I cannot prescribe exercise depending upon a heart rate in a patient with a cardiac disorder. Okay, so cardiac disorder I always use the rate of perceived exertion, the feeling perceived tired or the exertion, Vogue scale. If you see pulmonary rehab, I can use with respect to heart rate. Okay, so these kind of things will come. And not only cardiopulmonary or exercise physiology, remember that anaerobic and aerobic metabolism. So you know that picture. Anaerobic means glycolysis. When it comes to aerobic means Krebs cycle. So this flow chart has to be memorized. There's nothing you can do. It is actually an undergraduate level education what they have provided. How this various changes in the molecules and metabolism happens, macro and micronutrients. So in that, if you see carbohydrate, fats, and this which is the other one in the macro, proteins. Okay, and if you see for micronutrients, the minerals and the vitamins. Okay, so these things, see how proteins are metabolized. Prepare one answer. How fats are metabolized. Okay, metabolized means how fats are broken down, which structures are involved in that, what are the processes, where it is stored. Okay, fat reserves, where it is stored. So these are things. So and carbohydrates, definitely it's much easier. So these things, then you know that you can always bring your answer towards that if the question comes with relevant to what is called as a resistance training, nutrition and exercise physiology. That means you know that it is about proteins. Okay, more predominantly anaerobic metabolism. So you can add anaerobic also, you can add about the protein metabolism also, okay? And you can also add about exercise aspects. Because every exercise physiology means from physiology we have to get it to our exercise prescription, okay? And the influence of fatigue, lactic acid, So all these aspects you can tell, lactate threshold, how to monitor that
Right.
in a laboratory or a exercise environment, okay, during resistance exercise. So like that. Research methodology,
Yes.
the conflicting thing, I think it's between the statistics, okay. Especially you might be given some kind of a data, and then you may be asked to calculate some of the measures, okay, if previous question papers have asked like that, okay. Otherwise, if you see, common questions in research methodology always involve reliability and validity, okay, and you also have what is called as structure of a research proposal and explain it with an example. So this is a common question. In fact, it might have been repeated in many years, the same question also, okay, in research methodology. Even if it has come last time also, still it can come this time also, okay. It is just to see that how the candidate explains at least their own project, okay, because you have submitted the dissertation, you have completed the research. So that means you are supposed to understand what is the proposal and why introduction is there, why statement of the problem is there, what is purpose of the study, what is objectives, what is the hypothesis, null hypothesis, what is that which is methodology, why ethical approval, sample size, sampling, you have what is called the data collection, then treatments or data analysis. So everything, why references. When you are explaining proposal means you should tell two standard styles of references are there. Okay, so in that then it goes. Other than that, if you see, very narrow type of research questions could be the list what is called as the journals that can be related to evidence-based practice in physical therapy. Okay, so that's a very applied question. So you need to know the names of journals. So in normally when you have to see for research, which textbook you can read in master's level. There is a textbook written by Portney, Portney. I think Lisa Portney or something. I don't know the first name. Foundations of Clinical Research. Okay, that is the textbook. So that's a very, very valuable book. The examples are very simple and easy to understand. It is a big book, but it's worth going as a reference again. For research also there are articles. If you want to see like types of randomized control trials. So put it like randomized control trials review. And then when you are searching, you will get research journals where the review article is written on randomized control trials. Okay. So you will get content. Compare a systematic review with a meta-analysis. Okay. Short question.
Right, sir.
Or
Yes.
in research also you can have a sampling, types of sampling, short notes. Okay. Or you can have sample size estimation formula. This formula you have to memorize. Okay. One is one type of study which is like you are comparing two treatments. So experimental study for that one formula memorize. Sample size estimation. Another one is you memorize for prevalence studies. So if I am asking for prevalence of musculoskeletal pain in smartphone users, okay. So then definitely that there is another sample size calculation for the prevalence or the cross-sectional studies. Okay. So both the things, see that sample size estimation and that will suffice, because if you see case control study, still that is also comparison between two groups. Okay, it is observational. Study designs can be again detailed question. Compare and contrast different types of study designs and their ethical issues.
Okay.
And again, ethical issues in research separately also can come. If research is combined with administration and ethics, then it will come as WCPT Code of Ethics, or you see for what other things can come in ethics? Yeah, clinical practice ethics. Okay, so ethics is patient ethics, then research ethics.
Yes.
Then you have multiple associations. They will tell you to compare between the code of ethics of Australia, America, or UK. Okay, these three are major things. So APTA code of ethics, CSP code of
Yes.
ethics for UK, and APA, Australian Physiotherapy Association code of ethics. These three, and WCPT code of ethics. So these all together, you will see the comparisons also. You will know, but you need to know mainly if APTA means how many are there statements. Is it 12 or 14? CSP code of ethics means 8 is there. WCPT means 16 is there. Okay. APA means only 12 are there. Okay. So that total number, because points and all, you are not going to remember theoretically, and we are not going to what is called as going for an audit or inspection to another place. But sometimes you see in administration, they will ask about specifically the establishing a PT department in a college. So what are the infrastructure requirements? Okay. And for a course of BPT, what are the faculty requirements? So these kind of things will come in short notes. Is it like administration ethics together with the research, or is it separate?
No, it's with research. It's in paper one, but
okay. So sometimes it will
it's
be
in
like
paper
mixed,
one. But
and
we
it's a
have
very boring paper. Okay.
yes, because paper one is ethical issues like maybe research and normal professional ethics, and of course it also has this other research methodology, structure, everything, and exercise physiology. So paper one has all this together. Yes, very
Okay, so remember that
elaborately
when you
explained,
have
sir.
multiple
Wonderful.
subjects, this now what I'm going to tell is the most important thing. You have subjects which are very boring. You also have subjects which are very interesting. Okay, most of us psychologically, we all know that the most interesting subject already you have read enough number of times. Okay, you are happy to give that exam paper.
Yes.
Okay, and even if you don't study also, you can manage that paper. Okay, but the boring one is the challenging one. So once you have taken the material, I would suggest that first thing in the morning, make sure to start with the boring paper. If you are preparing, like for example, this 3 hours I have to prepare for my exam. So in that 3 hours, you keep it like the first 1 hour is the boring subject, or at least the half an hour the boring subject, whichever. And then you intersperse with the interesting subject. Okay, interesting subject is more of a revision. You are just studying for your enjoyment. It is a recharging experience for you. Okay, the boring subject is like a responsibility. Okay, I have to do it. I cannot read without reading, and I don't want to read it again. Okay, anything happens to that paper. Okay, so somehow I want to clear that. So when your mind is fresh, read the most difficult subject. And how to read that?
Yes.
First 10 minutes, read very fast. Fast. Don't try to remember anything. Okay? Just read. When you are reading mind-wise or verbally, whichever is there, read faster than usual. Okay? Because usual speed, if you read, you will get fatigued. And if you are trying to
Yes.
understand also, you will get frustrated. Okay? Because it is very difficult one. So what you need to do is just to read it. This is called as a rapid reading. Okay? So
Rapid
sometimes what
reading.
happens when we read
Yeah.
it faster is you will only know some items here and there. Okay? I read for half an hour, for example, and I read it very fast. At the end of it, I might remember only 5 words. Okay? So I
Yes.
know that this topic means the 5 words. So you are happy that that 5 words you are remembering. And next time, after reading the interesting subject, another 15 minutes, the recharging one, you come back to the most difficult again. Continue the fast reading, the rapid reading. Okay? Keep on rapid reading, rapid reading, rapid reading. And you need to get in your mind that, yes, that subject, once I have read, don't check what you remembered. Okay?
Right.
Because otherwise you will be sitting only 2-3 pages, and after that you will skip and go to another 2-3 pages, then close the book and keep it, and then see that that same subject, any other book is there, then another read 1 page, then close it and keep. Okay? And finally you'll be thinking what I'm going to do with this paper. Okay? So best is to tackle it with fast reading so that you will get
Right.
at least 4 or 5 words, the catchy words. Next time when you are reading, even fast, same fast reading, you'll remember more than those 5 words. Okay? This is human
Yes.
tendency because your repetition and practice is coming. Challenge is when already I am not understanding with usual speed and I am not trying to, when I am reading fast, how will I understand? I will tell you, this research methodology textbook and all, you can write the same textbook in 150 pages, same textbook you can write 1500 pages. So these authors like ethics and administration, that leadership, personality development, all these authors, simply they make like number of pages. Okay. So you
Right.
might think that it is one chapter is there, 10 pages are there. But when you read fast, you will come to know that it is only this, okay, this 5 points are there. Okay. So what you remember
Right.
alone is sufficient. And anyway, the review article will give a better idea. And you know previous year's question papers also, you know the topics. So this both you can mix and match. Other than that is this
Right.
textbook. So in this, again, rapid reading, rapid reading, rapid reading. You will never do slow reading. Okay. In that difficult subject. Okay. Another thing is,
Yes.
you might like a particular snack, a particular food. You might like to have coffee, for example. Coffee you like very much. It's a challenging thing to ensure that that tough subject you read with that good snack what you are having. I am telling an example what I used to do. I used to have that roasted groundnuts, the masala groundnuts. So I used to keep munching that when I am reading. Okay. I also had a placebo that they used to tell that you take groundnuts when you are studying exams, means your memory power will be good. Okay. So I used to feel that anyway I'm eating groundnuts, so I'll remember. Okay. So whatever way, but our belief only makes us to retain the content. The moment, one thing I'll tell you, when I take the book, I take it like, oh, I don't know whether I'm going to remember or not. Definitely, I cannot remember.
Right.
But at the same
Yes.
time, yes, this book I am taking, I have to read the book, and today morning to evening, I am going to do quick reading and I'm going to complete this book. So one day, possible. Okay. And next, which I also told you that if visually it is anything is difficult, Okay, when you are observing in the book and seeing printed material, visual fatigue, lot of things come. So always ensure that you have bright lights like something like this, which is either colorful, okay, so that in between periodically you can look at these lights, so that your eyes are getting that what is called as the contrast between brightness and darkness, okay, rather than the black and white text, okay, which is there. Also, every content, when you are remembering 5 sentences like that, think of how to put it as a flow chart, how to put it as a table, how to actually make subheadings, okay, out of that content, okay, so that you can be using the same strategy in the answer sheet. And the next thing which you can do is also listening to your favorite music when you are reading the tough subjects, the difficult subjects, because this music is your favorite music. What type of music? Which makes you dance around. Okay, you listen to that music, you start like wow, okay. It is really like something which I really had a good party. I have pleasant memories, or that favorite music band or a musician. So you know that and see that these kind of subjects, keep it. And when you are reading also, you should be like, yes, yes, I am happy, I will be relaxed only. Okay. I will not allow that difficulty of that subject to get into my brain. Okay. I will be happy because maximum memory, all the areas will be activated when you are happy. Okay. So we have to actually combat that, because MPT is not for sitting with textbooks. Okay. And especially you see that every author has their own style of filling the pages. Okay. If I am writing a textbook, I don't want to write for 100 pages. I will always write for 700, 800 pages. So content can be exaggerated in textbooks. So that is why big textbooks, especially non-clinical textbooks like exercise physiology or be it a research methodology, make sure that, and if you don't like it, then incorporate things which you like together. It may be a group study with your batchmate. So interacting on Zoom, for example, if you directly they are not accessible in the house, they cannot come. Even if you discuss 15 minutes, you tell that, see, tomorrow this topic, night 8 to 8:15 will exchange. I will exchange 15 minutes. You exchange 8:15 to 8:30. Half an hour. So keep it like that. So then what will happen is, definitely when you actually listen from your own colleague or batchmate, definitely additionally memory will be there. And what is called as technology you can utilize, okay, for your memory. Also another thing in the BPT preparation, which I highlighted, that you can read it, you can record your voice, listen to it. Okay. This you can do for the very important topics like previous year's question papers. You have seen 10 question papers. In that 5 question papers, particular topic is repeated, either in short notes or detailed question. But that topic is a difficult topic. So definitely you should do multiple strategies together for that topic. Okay, because that topic deserves that importance and dedication to prepare. Okay. And above all this, answer the previous year's question papers right. Because taking notes, I have already told, you can take notes from textbook also, you can take notes from video, audio. A YouTube video also explaining, many are there. For example, an SPSS analysis, parity test, and parity test. Short videos are there, 10 or 15 minutes videos. Directly from that also. Or be it our AOMPT video, when you are listening, you should take notes. Okay. You always take notes. You have prepared extensive notes for all the courses. So taking notes helps you with writing speed. At the same time, 3 hours writing speed. So that you have to work upon it. Because BPT students, at least they can manage with writing for 3 hours. At MPT level, writing for 3 hours has been a biggest challenge. Okay. Because our body is not the same as it was before. Okay. And there are a lot of things which we have to improve in our endurance. Okay. When you are writing. So, uh, time that pacing of content. Okay. As I have told for BPT. I think you
Right.
attended that section also, webinar also fully. I know that.
Yes.
Okay.
Yes.
So, you can definitely incorporate those inputs here parallelly so that it helps
Right.
the bigger picture. Mhm.
Yeah. Perfect. Yes. So I think I totally I agree with all the points you have mentioned. The fast reading thing. Basically, I've experienced this, and I did a small course last year, rapid reading course, which has all these strategies of reading big books in a very short period of time. So rapid reading, as you mentioned, it's just skimming and scamming, what they say. So you just skim the material, scan the material first in the initial phase, right? And then you read lines, like, you break it into maybe a paragraph of four lines, So you skim that way. So you recollect only the words. And the best thing of that was, before reading the book, have certain things in mind, or you can put down on paper. Like if I want to read research, at least I know certain things, what can be there in the book. For example, sample size, as you said, or introduction, maybe. Whatever knowledge we have from a general perspective, maybe we can put on those words on paper. So while reading, it makes sense. Like, okay, this is what is there. I know what I'm looking, what I'm expecting from the book, basically. So this method works fantastic. I've practiced this, so I can vouch on this method. Of course, difficult subjects, yes. I think the biggest challenge for MPTs is managing the clinic, managing all the other schedules, and studying. So that's it's not like you don't have to study the whole day, but whatever time we dedicate for studies has to be really fruitful. So whatever you have said today, I think it's going to enhance. It's like uh, strategic studying instead of just going through and through with all the books and finally we don't recollect anything. So this method is fantastic. Yes. Uh, I think I we've covered almost everything, I suppose, from the examination point of view, the theoretical point of view, rather. So, how about practical aspects? If we see from the practical exam point of view, what should what should we look forward to, or what should be our way of organizing our mind when we actually go for the practical exam? Because we have been seeing patients, we treat patients,
Yeah.
definitely. But when it's like, oh, somebody's going to take a practical exam for that, I think then it's a challenge. So how can we deal with this thing?
First and foremost, the practical examiner is evaluating you because you are going to be a teacher. Okay.
Right.
So it's obvious that your teaching skills, its was is evaluated in the practical exam. Although the patient type is given
Okay.
to you, condition is given to you, your explanation should be like as a teacher.
Okay.
So you should think that the challenge is, that is why I say MPT students, if you are teaching the BPT students in the college frequently, definitely your practical exam will be better because the teacher inside you
Okay.
will come out. The best example is a patient with lumbar radiculopathy is given. Okay. The examiner has told that this is lumbar radiculopathy. This is the long case for you. So you proceed. Okay. So the practical performer tells you first and foremost is receiving the patient and then reading the case sheet. And receiving the patient, that involves introducing to the patient that I am the therapist and I'm going to check you. Please feel comfortable and wait for a few moments until I go through your case sheet. So self-introduction, maybe by name, I am the physio and all this. Okay. And after that, I go to the case sheet. Then I go to the examiner only back. Okay. If, for example, sometimes internal examiner gives the case, sometimes external examiner gives the case. That example like lumbar radiculopathy, or it may be a chit, which is a chit which is written that lumbar radiculopathy. Okay. There may be 5 conditions they would have kept, tell you to pick one. You had picked this one, so it will have come. So make sure to keep the chit safely till the end of the exam. Okay. Because even if you have answered very well, in the end they will tell, where is the chit? So you should not have lost it. Okay. Just for joke they will ask, but you just keep it safe always. Okay. And when you actually approach, look at both examiners, see that and explain, teach both of them. Like that you should talk. Okay. The challenge is, in your mind you should feel that I am here to learn in the exam. Okay, like BPT practical, I told you that your objective of an exam is to learn only. Okay, and then you see for both of them are senior most professors, but you have to see them as students who are just willing to learn from you. Okay, they are sitting. So, and you should also make sure that you are humble and you are teaching. If I am starting with this case, I will say that from the case sheet, I would like to know what are the causes of lumbar radiculopathy. Maybe a space occupying lesion, then it is a red flag. So I will like to rule out the red flags and see that if these conditions have caused the lumbar radiculopathy in this patient. If it is an infection or an abscess which is causing compression of the nerve root. So I want to rule out. So I will ask the patient constitutional signs and symptoms. I will also check in the case sheet whether there are any lab tests that are done, or also the constant type of symptoms, night symptoms. So these kind of questions to clear that I will ask, sir. Okay, so this like that you can narrate. So first thing. So they know that you are ruling out the red flag. Okay. So this is something which commonly a BPT student will never tell. BPT student will always tell,
Yes.
lumbar radiculopathy commonly occurs at L5, S1. Next common level is L4, L5. Okay. They go condition wise. You are going to go reality wise. Okay. So first I will do the red flags clearing out in the case sheet so that contraindication is ruled out. The next one is, I will also like to see what is the medical reports, because there is a case sheet, there is a physician who is referred, or they have already seen a physical therapist. So I need to show the past progression, what is documented in the case sheet, so that I need not ask the same questions to the patient. Even the subject may be a boy who is a BPT boy, who is a model. But still you should be very, very careful to maintain that boy as that same 50-year-old lady with the lumbar radiculopathy. Okay, so they have given the case as 50-year-old woman with lumbar radiculopathy. So that means you should have that. And also tell that because she is 50 years, I will ask her about the menopausal status. Or is it like how many in the childbirth and post after that, whether it's any relationship, osteoporosis or anything, any chronic other medications. So these kind of situations I will ask. Did she undergo hysterectomy? So many things you can ask. Okay. And always remember that to think like that 50-year-old woman is there. Okay. So same like that. And I will also check her body mass index. If she is obese, then I will decide on which is the convenient position. Okay. I will also ask her whether
Mm.
symptoms are changing with the positions, which are the aggravating and relieving factors. So these kind of things. Then they will tell that, okay, these are things, okay. The patient is having pain on bending forward, lifting weights. Okay, she is a homemaker.
Mm.
So after working for this many hours, then she has the shooting pain, okay, into the leg in standing. So after standing for long hours, the shooting pain comes to the leg. Walking is not aggravating. So
Mm.
they'll give some fill in the blanks. Okay. So now you proceed like that.
Okay.
When they tell 5, 6 points like this, immediately you tell, pardon me, sir, let me write down. Okay, tell me one thing. So let me write it down once. So ask them to repeat.
Yes.
Okay. So ask questions,
Okay.
clarify. Do not jump into conclusion that okay, stenosis, okay, because standing, so shooting pain is coming,
Mm.
extension, so stenosis. So that is the picture like that. Because they would have told 6, 7 points. If it is faster, means you have every right to slow them down by telling that, pardon, sir, I just wanted to clarify all these points. You mentioned that homemaker, then you told that standing and cooking and that time shooting pain is coming. Hmm? Prolonged sitting means only back pain. There is no leg pain, you told. No sleep disturbances, you told. So these are things. Okay, sir. This much. Am I correct, sir? Did I miss anything, please? Like that you ask. So it becomes like, yes, you are serious about the information what they are giving. You are communicative because that is what is expected at master's level, not to miss anything. Okay, and also you are noting down. Okay, you are not very careless. Like I am remembering, I will remember. I know the conditions. Okay, like that. So then it gives you an added opportunity to think again also because they might have told something first time. Second time when you are writing down, they will tell something else differently also. Okay, so it makes things easy for you. Okay, and then you go ahead with what is called as positioning the patient, then the exposure of the part, and I will see for local contraindications if there is anything. So I would wish to actually see
Mm.
that you have told that pain is intermittent, sir. So pain will aggravate only this times. So I will ask her what is the present level of pain. I will also ask her to mark the pain in the body chart because in
Yes.
BPT you don't document, you don't talk about red flags. Okay, in BPT you don't talk
Yeah.
about the body chart, the symptom distribution marking in the body
Yes.
chart or pain diagram. We never use that. Um, and next one is in PPT, no student usually tells that what is called as the severity, irritability, nature, stability of the symptoms. So
Mm.
severity in terms of visual log scale, irritability, non-mild,
Mm.
moderate, severe, irritable, or the nature being constant, intermittent, or the type of pain. Stability, which is like 3 months the patient was having symptoms. So it is stable or unstable. If it is stable means whether it is worsening symptoms or recovering symptoms, okay, reducing spontaneously recovering
Right.
symptoms. So patient is feeling better
Mm.
compared to last week. So that means you know that I will wait and watch for some more time. I'll just give her activity prescription and advice. I will not modify her routine more because already she is getting better. Okay.
Yes.
So 3 months before I had radiculopathy, but last month I felt half. 1 week before, now I am having only 10% of that radiating. Occasionally I feel numbness in the foot. So in this situation, you don't have to check
Mm.
SLR, you don't have to check the spinal movements, you don't have to give manual assessments, okay? You don't have to nerve palpation and all these things because you know that 90% is
Yes.
recovered, 10%. So
Yeah.
at this stage, activity prescription is enough. And we know that in musculoskeletal pain, always that final stage where the return to activity is aerobic and functional
Yes.
pacing. Okay, how we tolerate the symptoms and then we move
Yeah.
on. And we are not
Mhm.
going to examine whether it is a myofascial trigger point is there or not, or joints, just the patient joint dysfunction is there or not, or piriformis is tight or not. Okay, but the same thing comes in
Mhm.
patient who
Mhm.
have worsening of symptom, now severe symptoms. So then immediately you tell
Yeah.
that because the symptoms are highly irritable, I would like to examine in relief positions. So which are relieving the
Mhm.
patient's symptoms. Okay. Because this is something which is very, very important and it's been a core content of AOMPT courses. Okay. That we don't do an SLR,
Yes.
we'll do an offloading for the sciatic nerve. Okay. Because there is a radiating
Yes.
pain. So that means there that picture comes. If the patient is having severe pain, means what he will do. Okay, so this is what they want to see.
Mhm.
In BPT, what the student will answer usually is keep the modalities. I will wait for the pain to subside, then only I will examine. Okay. So in your situation, you
Right.
will tell, I have ruled out the red flag. I know that it's a mechanical pathology, but the symptom is severe. So definitely I can mechanically influence and relieve it because patient is telling relieving factors are
Yes.
there. The relieving one is flexion because sitting. So
Mhm.
this is my decision making, sir. Huh? I would like to see that whether there is a directional preference. The first and the foremost thing in lumbar radiculopathy is the directional preference. And then, if you are
Right.
remembering, tell that according to McKenzie concept, okay, mechanical diagnosis and therapy. So
Mhm.
first I will position her with the flexion.
Mhm.
So I'll put the pillow under the abdomen, make her prone. If
Mhm.
prone is difficult, she is obese, then I will make her in side lying only with the flexion position. Preferably the
Mhm.
radicular side higher, and I'll put the pillow or the roll so that lateral flexion higher side the foramen is open.
Mhm.
Okay. When I'm keeping the
Yes.
radicular side higher and foramen higher, if the patient still not getting relief, I would suspect it is posteromedial disc herniation. Okay. So in that situation, I'll keep the radiating side lower with the pillow. Same side lateral flexion will relieve. Okay. Because it is posteromedial disc herniation.
Right.
So
Mhm.
when you go into details, and especially you are telling about, I will look for pain reduced, pain not reduced, peripheralization, centralization, okay, or patient is having
Mhm.
aching pain in the back, numbness in the foot, shooting pain in the
Mhm.
thigh. So there are three symptoms. So that means aching pain in the back comes with sitting. So I suspect that it is muscular pain because it is postural. So I will do a
Mhm.
myofascial evaluation.
Yes.
Whereas the shooting pain along the thigh must be neural, but that neural should be a mechanical neural one because of a compression or irritation at the foramen. So there, that patient should be given sliders techniques for the sciatic nerve.
Mhm.
Whereas for numbness, I can do a nerve massage because numbness is because of circulatory disturbance to the nerve. Okay, so it
Yes.
is like, uh, of course, neuromanual therapy. We have got every aspect. Okay, the interface, compression there, foramen, or be it a slider technique for peripheralization, or be it a numbness which is vascular. So you will do the nerve massage. Definitely.
Right.
But it's difficult for everybody to apply the problem oriented approach. See, for example,
Mhm.
the examiner will expect that you cannot tell the answer like it depends on each and every patient presentation. You have to tell either patient has constant or intermittent. Intermittent means I'll check for directional preference. Constant means I will check for red flags. Then after that, I will see which are the ones which are relieving the symptoms. Okay. So
Yes.
every tissue will be you can evaluate as relieving. Sciatic nerve offloading position is there. For facet joint, you
Yes.
have relief positions, which is opening position. For a flexed facet, open position is a relief position. For an extended facet, closed position is a relief position. Opposite one will be aggravating because it is corrective. Okay. And spasm, the muscle is kept in the short-term position. It's a relief position. Be it a quadratus lumborum or be it
Right.
piriformis. So next is you go for myofascial means reciprocal inhibition. Myofascial means the kinetic chain based treatments far away from the region where the spasm is. Okay. And
Right.
incorporating motor control for myofascial. And articular open techniques. So you do the Maitland's mobilization grade 1, 2. And you also see for what is called as a distraction techniques, so that to
Yes.
gently influence mechanically the joints, okay, to relieve the symptoms also. And you also know that
Yes.
manual traction is very useful in radiculopathy. It can be as a traction SLR, or it can be as double leg rotation techniques of Mulligan, okay, for lumbar radiculopathy. Or you can also use what is called as articular, spinal mobilization with the extremity movements. Okay, you can give pressure on the spine at the same time, do a slider. Okay, so you are not going to give tensioner to the sciatic nerve when there is shooting pain. Okay, only numbness is there,
Right.
shooting pain
Right.
not there. I can do tension techniques. Okay, I will evaluate the SLR
Yes.
that time. Okay, how will you do an SLR testing? You show on this patient shooting pain is there. How will you do? That means you should tell. First, I will examine level 1 of examination, Michael Shacklock. I will do only the dorsiflexion.
Okay.
With that dorsiflexion alone, the shooting pain is coming means I need not check the SLR. Okay?
Yeah.
Or side
Right.
lying the patient is there, just to do the neck flexion. Neck flexion alone is bringing shooting pain from back to the foot means I need not do the slump test. Okay? So imagine SLR negative, then what will you do? I will check for slump test. Because the SLR is negative, I have to perform slump test. What is the difference between SLR and slump test? No, slump test checks the dura mater, neuraxis, and slump test is tension dysfunction. It checks. SLR may be because of intervertebral foramen compression, but slump test may be the canal compression. Okay, so I can check that,
Yes.
and you can definitely tell. And again, I will evaluate the neurological examination. I will see whether it is L2, 3, 4 dermatomes or myotomes involvement versus L5, S1, and then plan for whether I need to evaluate femoral nerve bias or I have to evaluate tibial or common peroneal bias. Okay, so tibial bias is more of that S1. Okay, L5 is the common peroneal.
Yes.
Okay, because great toe extension and dorsiflexion, all these are L5, whereas plantar flexion is S1.
Yeah.
So you can tell this way. I will try to see that. Also, region of symptoms from body chart. I'll come to know distribution of tibial nerve, distribution of common peroneal. Okay, where it is, or only femoral, or obturator, or lateral femoral cutaneous. So like that.
Right.
And then you can go ahead with, as the symptoms are resolving, symptoms have become more intermittent, as much as possible. Activity, so that it's very, very important in back pain patients. No protection from activity or bed rest more than 3 days.
Yes.
So these things, where it tells about the evidence, bed rest more than 3 days is ineffective for sciatica. Okay. So you tell that deconditioning is a big issue in back pain. So we should not promote disability. So as much as possible, I will explore what are the activities which the patient actually feels comfortable. Okay. So since the patient is sitting and then having back pain and things, I can advise her to do cycling. So it's easy for her to have it at home and do the activity for lower limb also. It helps rather than a walking exercise which she cannot do, where she cannot leave the home and go. Okay. So there are a lot of barriers. Okay. So those kind of things. And also, no, she will tell, I'm already homemaker. I am not having time for exercise. Then what will you do? Okay. Examiner will ask. So you should always tell that again that definitely it is tough for people to do the exercises like that. So that time I should understand that she's not realized the importance of exercises. So I should tell that this foot pedaling machines have come. So I can tell her that whenever you are cutting vegetables or when you are trying to mix something in a sitting position, keep doing the pedaling. Okay. So with that only keep doing, so that the same time you can do, and it will improve your strength so that your cooking can be better. You can do better longer term active in kitchen. Okay. So it can help you also, so that I will convince the patient. And most importantly, in communication, I will use motivational interviewing, because with motivational interviewing, everybody will get that responsibility that it is I have to decide my life. So it is like 24 hours. I need to do what is required for me. Okay, so that is, I will incorporate that. And it is chronic pain. So central sensitization, whether it is there, I will see. If it is there, means definitely I will give for graded motor imagery or virtual reality. So make sure that the patient enjoys that experience. I will also give a very simplified education of pain physiology for 5-10 minutes, so that the patient will get a better understanding about the pain experience. Okay, rather than being afraid, panicking, and if the patient tells that standing is producing the shooting pain, then I will see for activity pacing. So during the standing, keeping the leg up, during the standing, shifting weight from one leg to another. Okay. So these kind of advice I'll give, and not for sustained standing at one position or in one leg like that. So you can incorporate multiple dimensions. Okay. And tell them that if she tells like this, means definitely we can do that. Whenever an examiner tells, all this you have done, patient has not improved. So what will you do? Okay. Then you should tell, there are always a probability where patient improves, patient not improves. Okay. So we need to see for 24 hours. Because we have given the treatment, we have given the advice, patient will come back tomorrow, and we have to see 24 hours reassessment, then we have to plan. Okay. And okay, 24 hours, 48 hours, the patient comes and tells my pain is same. So what will you do? Okay. So then you will tell that I'll discuss with the surgeon who has referred, that so that interdisciplinary, we'll get a picture that why the mechanically behaving symptoms, mechanical treatments is not getting relief. Okay. Sometimes the relief don't come mainly because of central sensitization. Sometimes people do have psychological issues like stress the patient might have. So in that situation, autonomic nervous system may be heightened. So I might give a what is called a thoracic spine techniques. Okay, thrust manipulation or thoracic spine mobilizations. Sympathetic slump, that can be given as a slider. So various techniques I can utilize, and see for relaxation techniques for stress, anti-stress. So that is also, and music therapy during the activity, because you have to see for she is doing the activity, homemaking. During that, she has to just listen to the music. So advising everything in a holistic perspective, I will attempt. Then you can look at the examiner. The examiner will tell that, okay, even now also she has not improved, what do you do? Okay. So then definitely you will tell that
Okay.
this can happen. Then I will try to improve the pain tolerance, get her into exercise, aerobic activity, live with the pain.
Hmm.
Okay. So pain will be there. Don't allow your pain to control you because you are going to become
Hmm.
dependent. So you should keep the pain. Without the pain also, you are able to do many activities. So keep increasing those activities. Okay. So for
Right.
example, the positive focus. Okay. And then I will counsel and I will give. I'll try to cite some examples of previous patients to motivate this patient so that they will also do. Uh, if the patient is not cooperative for the exercise and activity also, I will arrange a group therapy. Similar back pain people, everybody, I will keep them together and I will so that other people who have recovered out of the chronic pain, they are giving motivation more to this patient, so it will help like that. Then the examiner will
Right.
tell, okay, enough. Okay. Uh, so you will never recommend for surgery. Yeah? Then you tell that
Right.
as a physical therapist, I will try my level best till every end. Okay. I will not
Yes.
recommend a patient for surgery. It is the decision of the surgeon to decide when to operate. Okay. I will not lose hopes until and unless till the very end I have done. My last point will never come. Okay. So I will do my best for the
Right.
patient as much as possible, sir. This is what I think, sir. Anything else, please, you can highlight that so that I can learn. I'm ready to know that.
Right.
Okay. Maybe some things I would have missed,
Yeah.
or maybe some errors I might have made during this. If you'd like to correct and you want to show me anything, please uh,
Hmm.
show us so that I can know. Okay. Like that also you can ask. So that means you are going humble. You are at the same time ready to
Mm-hmm.
learn. You are confident as a therapist that you are not washing your hands off. Okay. Because these are all
Mm.
the qualities which is expected. Ultimately, they want to get an answer in the end that yes, I cannot do anything more. Okay. But that you should tell it very positively that I will give it my try till the very end. And
Yeah.
that will show that you are passionate as a clinician. You are strong to be
Mm-hmm.
a leader as a teacher. Okay. And anytime in contradicting statements, like for example, um, spasm, I want to give positional release technique. Okay. So you are telling that.
Hmm.
So they are telling that, so you can't give hot pack. Hmm? Then you can tell
Hmm.
that if the patient tells that with the hot water bottle or hot water fermentation or taking bath with hot water, warm water, she feels better means I will prefer to use hot pack also. And then, if the patient not telling those things, then you will not keep hot pack. Okay. Then you should tell that, yeah, yes, sir, because it is like thermal aggravating relieving factors. We know that it is only the penetration is only superficial. So that thermal change, it should be related to the placebo. Okay, what the patient had actually. It can be a central sensitization also or placebo. So either way, if that is benefiting the patient, then only I am going to give. Um,
Yes.
Otherwise, for spasm, I would rather see that whether cold pack will help. Okay, because that actually helps the nerve condition velocity to reduce. So that might actually help
Yeah.
rather than the hot pack. But if the same it is in a elderly woman who is having hormonal imbalances, who is having peripheral vascular disease, so likely that
Hmm.
vascularity may be proper. So I will not give any of the thermal ones, and I will make sure that if at all the heat is always beneficial, but that heat will be good as a warm up. Heat will be good as
Yeah.
gentle movements rather than keeping the superficial heat as a hot pack. So it depends on the patient's cooperation. So I can decide with the hot pack also just after some motivation and mobility comes. then I can give the mobilization movements and everything activity, so the patient will do better. So you can always try to incorporate what the examiner is giving as a suggestion. Okay, why can't you use means you should incorporate that, and then you should tell that added once I will do these all things. Okay, you will not tell that I will not do that unless and until if it is like they're telling like, can you give dry needling? Okay, then you can tell that it's an invasive treatment method. I need to be first clear that whether the patient is comfortable with the needling. And the next one, indication for needling is not spasm. There has to be trigger point, but there should not be spasm. So this kind of situations I am not going to give. And low back area dry needling, as much as possible I will avoid, because there are visceral organs and I don't want to unnecessarily create it. And if patient is not comfortable, definitely I will not choose that. And tell very strategically. Okay, so if it is to do with piriformis, I will give the needling. But if not for the quadratus lumborum, I will not. Okay, so be very clear in that, and also tell that it's a useful technique, sir. But I am not a certified practitioner as of now, so I am not going to apply those techniques now. So be open to tell that. Okay, because it is an advanced technique and invasive technique. So unless we get properly certified and properly practiced, I would not use that. Okay. Whereas manual techniques, the hazards are lesser. Okay, so we can easily use. Okay, non-invasive ones. Okay, you can also tell, for example, cupping can be used. Okay, you can tell IASTM can be used. So if they ask like anything else you can use, or you have given all this, it's not working, then you add these all. Okay, cupping, IASTM, okay, all this. So then it becomes, or even taping, adjunctive method of taping and then seeing for spasm means inhibitory kinesia taping or rigid taping itself, splinting the muscle. So these all things will come as a extended discussion. Okay, so your presentation was extraordinary, and that's why they are coming to the advanced questions. Okay, if at all they are asking about special test, then they are going to biomechanics, then they are going to anatomy, means we should know that our answer is very bad. So watch out, be very steady before giving any answer, and make sure that anatomy answers you should never make a mistake. Okay. So sometimes just to check, the examiner will tell commonest levels L5 S1. No. I am telling L4 5 only common. So what is your point in this? Okay. Then you should tell literature tells because of the angulation of the S1, the sacrum. So the disc is shearing load is too much on the L5 S1. So it happens. If L4 5 common, it may be in people because it is the posterior tilt or because of sacrum in a counter rotation. So these kind of situations, maybe the L5 S1 may not be the one which will be affected. So L4 5 can be affected. So there are conditions in which it can be, this can be most common, that can be more common. It is only the data research which is there. Further future research or a different type of population will show difference. A patient who has hyperlordosis likely to have L5S1, but hypolordosis may be likely to have L4, L5 also, sir. So can be there. So you just tell 2-3 factors and say that that will determine. Okay, and people with the standing and then more common. This lady, the case example you have given, so L5S1 I assumed, but the same is sitting. If the shooting pain was coming, I would have suspected L4-5. Okay, so these kind of things you can tell. I don't know whether it is a random guess or it is applied reasoning. You are getting the presence of mind to relate that sitting means posterior tilt, sitting means the counter rotation of sacrum. So L5S1 will not be L4-5 only. Okay. So these kind of things. Also, partial sacralization. Definitely, you are expecting L4-5 only can go for radiculopathy. Okay. So the sacralization level will be stable. It will not cause the radiculopathy. So everything you can add on and say maybe the associated features will be there in that patient. So that's why I'll try to evaluate more. Okay. Why L4-5 is
Yeah.
common. Okay. In that particular patient.
Right. Yeah. So
Right.
I think you have put up a fantastic scenario of a practical examination. I mean, you have elaborated it so well that I can imagine standing there in front of the examiner and answering certain questions. So it's more of clinical reasoning has to be strong when we appear for masters, because we can make out the differentiation between the bachelor's examination and the master's now, very, very
Because your
clearly. Bachelor's
the
is like, okay,
challenges are
to the
given.
condition, to the point, finish. Yes. So, I mean, when we are going
They
up to
want
the
you to
level,
see.
it is needed. Yes. Yeah. And how effectively we apply the knowledge. I mean, of course, the patient-centered approach, basically, and judiciously using all the treatment techniques what we have learned throughout the years in our bachelor's. So applying the techniques, but giving a proper explanation for what we are doing, I think is something very, very important at this level, at the master's level. Yes. So wonderfully explained, sir. Yeah. So I think
And
from my point of view, we have really
there was
covered many things. Yes. Yes.
this question which was put by one of the viewer. PPT syllabus for entrance exam.
Yeah.
Basically,
Huh.
the colleges which have entrance exam for MPT means they are actually better level colleges, because colleges don't have entrance exam means they are just by BPT marks. Okay. So when you are seeing MPT entrance, what is the BPT syllabus means? That college, whatever is the BPT syllabus only is the entrance exam syllabus. Because if I am ABC
Right.
University, I have my BPT students and I am having MPT course.
Right.
For MPT, what is the entrance exam syllabus? The BPT syllabus of my college.
We the
Because I want my students to
Right.
clear the exam first, priority. Okay. So that is
Yes.
why entrance exam syllabus, if
Yes.
Manipal University you are applying for entrance exam means, look at the syllabus of BPT in Manipal University.
Hmm.
And my universities like Manipal, they usually give the mark distribution also. Exercise physiology 20 marks, biomechanics 40 marks,
Hmm.
and of course the PT, ortho, neuro, cardio. Okay, they give the division this much marks,
Hmm.
200 marks total entrance exam. This is the matrix.
Right.
Okay, how the marks are distributed.
Yeah.
And another interesting point about entrance exam, which I want to tell you, it may be a little funny, is when I am setting a question paper for the entrance exam, which is a multiple choice question, okay, MCQ, think as an examiner. What can be the one word answer? So if you are sitting with a textbook, you have got a catchy word, single word. So that can be an MCQ answer. Okay. So special test can be there, types of gait can be there, or it can be what is called as the disease condition. The name can be there. So clinical feature can be given and asked what is the condition. Okay. Or it can be the uh, description of the test and then the name of the special test. So it can be that one word, whichever keyword I can give as an answer will be the MCQ. Okay. If, for example, I have 5 options, 5 sentences means that cannot come in MCQ. Okay. But at the same time,
Right.
if Parkinson's disease, so that means I know that rigidity, bradykinesia, and what is called as balance or the posture issues or tremor, rest tremors. Okay. So tremors,
Yes.
rigidity, and akinesia. So these three features of Parkinson's disease. So then the question in MCQ will come as, which of the following is not a clinical feature in Parkinson's disease? Okay. So,
Right.
okay, rigidity. Here they put spasticity in that answer. So you have to choose that spasticity. So in MCQ, also another thing which you have to notice, that some options come like A, B, both A and B, neither A or B, neither A nor B, okay, all the above, none of the above, okay, these kind of options will come. So these kind of things you have to be watchful, because it's likely that those combined option will be the correct answer. If there is a question all the above, definitely it is likely to be a correct answer. But none of the above will never be the correct answer. Okay? So most of the time, okay, none of the above will never be the correct answer. Okay? And some questions come with which of the following is not a clinical feature. So the not you should not miss. You should be careful. Okay? And also in entrance exam is the negative marking. Right question you get 4 marks. Wrong question, wrong answer you get 1 mark minus. Okay? It may be there. In some universities they tell equal. 1 mark for correct answer, 1 mark for negative answer, wrong answer. So do not attempt any question unless you are sure, because what mark you got also you lose it. Okay. And next thing is, if I am the question paper setter, never I will keep the answer as the first option, because I have put the question. Option can never be A, because first itself why I'll give the correct answer. Okay. And also last answer also very less probability I'll give the correct answer, unless it is all the above or both A and B, like those options. Okay. Last answer only, because first option itself I will not start with both B and C. Never. A, B option will come, then C will come, both A and B, or D will come, both A and B. Okay. So like that. So think of first and last options, what kind of situation it can come. Okay. Very less. High probability that answers will always be B or C. Okay. In my logic, C will always be the maximum correct answer. Okay. C for correct, and first two options confusing, and C somehow correct answer they will put, and D they will put again another wrong answer. Okay. So what you need to see is, when you read the question, when you are looking at these options, think of which is not the answer, which is not the answer, which is not the answer. Eliminate them. Then you will get that probable thing that this may be the answer. Okay. So then put that word in that sentence and see whether it comes. Okay. So then you will get that picture that yes, it should be the answer. Okay. Because in MCQ, you cannot judge and jump into the question. Nobody is an expert to answer all the MCQ questions. Okay. But what you need to see is the trick of answering when it comes to questions, and putting that answer in that question and seeing this as a complete sentence. Okay. Then you see that, okay, the textbook you'll remember. Okay. What you read. Unless you put that word, you will not see. So that is why both the ways you have to read it. For example, the test is performed with the subject in sitting position. Knee is kept in 15-degree flexion. One hand of the examiner is holding the distal femur. Other hand of the examiner is holding the proximal tibia. And the examiner performs an quick anterior translation or shear force to the tibia. Okay. In order to find, in order to diagnose a soft tissue injury in a football player. So, which of the following descriptions hold true for this example? Okay. And then the options come like this. posterior cruciate ligament, anterior drawers test. Anterior cruciate ligament, Latchman's test. Posterior cruciate ligament, posterior drawers test, and anterior cruciate ligament and posterior drawers test. Okay, so 4 options come like this. So you are thinking of, okay, it is like anterior shear has come, so anterior drawers test only. So or Latchman's test only. So other than that is whether Latchman's test is for ACL or PCL. Okay. So that thing you should relate and see to that answer that PCL answer cannot be. So it should be an ACL with Latchman's or ACL with anterior drawer if Latchman's not there. Okay. So if the degree of flexion is 60 degree or 90 degree knee flexion, anterior drawers. Okay. So try to put this Latchman's, what are the Latchman's, what are the indication. Okay. Then you get the answer, other option, and then you can put. Okay. So MCQ, there are a lot of textbooks, but no single textbook will give you an idea to actually give the exam. Even the license exam of US, the textbook what they give as National Physical Therapy Examination, NPTE, Susan Sullivan only, the author. It also gives information plus it gives options. Most of the times they are case examples, and for the case example, the options are there. Okay, what will you do for this patient? So first I will give this modality, next is next modality, next is the exercises. Okay, so it will come like that. So that sequence will come. So that again, you will have to see that which sequence is, first you see the sequence and see whether it will suit the patient. Reverse thinking. Okay, rather than reading the question 5 times, putting one option and trying to fill. Okay, so see for first is thermal, next is electrical, next is exercise they have given. So first thermal, whether for this patient first thermal is needed? No. Okay, so directly I can go for exercises. So exercise, then after that functional training, and then sports specific conditioning. Okay, so this person is athlete, so sports specific conditioning. Okay, so make sure that the conditioning always sports specific comes as last in the rehab, not in the beginning of the treatment. Beginning of the treatment is exercises, and later you are progressing to the specific conditioning drills. Okay, so these kind of things you should try to relate from both the directions. Of course, the MCQ, very good textbooks are written by English authors, Indian authors, everything is available. You don't have an access to previous year's question papers for MPT entrance. It's very tough. You cannot get it. If at all, if it is available, it is only the recollected one, because you can't take the question paper and go out. Okay, when MPT entrance exams. So that is the thing. So make sure that try to prepare also one sentence, one word. So that only will be the MCQ question or the answers. Okay, so the keywords out of every subject and content. Okay, as per the mark division. Okay, so that way then you can prepare. A PhD entrance is also like that only. When you are asking for what is called as MPT syllabus only will be there for the PhD entrance. Okay, so but it will be the proportion of marks they would have given, like this much on orthopedic, this much on neuro, this much on cardiopulmonary or health and wellness, this much on research methodology. So this will be there in the PhD entrance. Okay, so that is again see that it is basically some may be involving English also, because in PhD they expect that your English has to be good. Okay, so then 10 marks or something for English, 20 for research methodology, and rest of the 70 will be there for the physiotherapy subjects. So like that PhD entrance can be there.
Right.
Yes.
Yes, sir.
So
Yeah.
we have taken more longer session today. Okay. So really good to see you that you are strong enough. And I know you are strong, but you are now recovering after the minor infection and everything.
Yes.
So it's good. And wishing you all the best. And of course, every participant here who is viewing this webinar definitely know that AOMPT, we do not just teach techniques. We teach how you can learn
Yes.
those techniques. Okay. And the same way,
Yes.
whether you are a BPT or you are intern or you are MPT or you are PhD, at every level, incorporating whether it is research or whether it is anatomy or biomechanics, every subject we have courses, and we always have the team which is actually able to assist you
Yes.
with their experiences so that you have a better learning experience. Pleasure to
Yes.
have Dr. Darshana because one thing is I'm seeing her after a long time. Now after this recent Omicron and things, and especially with giving the exam and actively participating is the best method of learning, which is ideally indicated for a best physio like Dr. Darshana. Okay, so it is always good that this webinar she could participate, and wishing all the
Yes.
participants also the best of luck. Whoever is giving an NPT exam, make sure to incorporate the strategies and do your best.
Yeah. So I would like to add on something to this. Like, I would give the full
Yes, yes.
credit to AOMPT and to you, sir, for my studies. Because the reason is I got connected with AOMPT 2 years back. Okay. Being away from academic, okay, for so many years and then again giving an exam is really a big deal. But I have all the course videos and I have attended all the courses live, which has made me the habit of putting down notes. I just opened up my all the books since the last year with of all the courses which I did with you, and I felt it okay. I've done so much, So now I just need to refer. So it's like it made my work so easy. Now I'll concentrate on the difficult topics which I'm really scared of, and the simpler ones I've already finished with you. I've already learned so many things. So it's only now putting down, organizing the answers, and using all that stuff and then making notes of it. So next best thing what I've done is with you is I have all the video recordings of all the sessions. So what I do is when I'm bored, I just play the video recordings, and I listen. That itself is like, I consider it as a part of my study. So I don't waste time. So even if I'm doing something, some other work, I keep on listening to the videos and I keep on seeing what is happening there. So that has really given me an edge to my studies. So I would sincerely suggest this to everyone, that please, please, please do the courses, whether it is bachelor's, BPT, MPT, and as you mentioned, even PhD now, that doing the courses is not only learning new techniques. Of course, for me, that is another thing. Last 2 years, I've learned so many techniques, new techniques rather, the advanced ones, which we now is like, trend in physiotherapy practices, which we haven't learned in our BPT curriculum, and we've missed certain things. So I have caught up all those things in these 2 years, and I feel so confident about it. And of course, as you mentioned that teaching itself, is going to enhance your knowledge. You always keep on saying this. So whatever opportunities you gave me to take up the webinars also, gave me that little confidence. Okay, fine, you can talk, you can speak, you can communicate well. So that is how I think AOMPT joining this, for me, the whole lockdown period was fantastic because I covered up most of my MPT studies during this period. So now I'm more confident. Theoretical exams, yes. Practical exams, yes. I feel more confident after you have, given us a picture of the practical exam, how it's going to be. But we feel nice because we have been listening to all these things so repeatedly from you. Yes. So when you were asking also, though you gave an example, but then yes, it started striking, whatever we have learned now, we are going to implicate it in our exams also. So thank you so much, sir. Wonderful. I'm really, really delighted that I was able to attend the session at the right time. It's like a breakthrough for me. Yes, sir. Thank you.
Okay,
Over to
and
you, sir.
we are also open to have people, members, to actually, for example, prepare for a question paper. They can prepare for their own question paper, which is previous question paper. Send us the answer sheet, pictures, and ask for an evaluation. Okay, like what are the things which I can
Ah,
better write in this paper? Okay, this is the question paper, this is the answer sheet.
yeah.
And the member writes seriously for 3 hours without looking at any of the textbook. So that way. And
Hmm.
after incorporating the suggestions, the member can also see for textbook and then write the same question paper. So that might take 6 hours because it may not be 3 hours because you are adding content from textbooks. And then also verify with us
Hmm.
that whether this preparation is sufficient enough for this question paper. Okay, so that is also possible. You can utilize that. And the same way, practical also. Like we have been taking case webinars and Ritu ma'am also have taken. But there the case webinars have always
Hmm.
been futuristic. Okay, like what we can do like that we have gone for. If you want me to evaluate as an examiner, okay, so I can ask like an examiner only all the questions. Okay, it's like for example, you have taken the
Yeah.
case, you have done documentation, everything you are presenting as a PowerPoint here, okay, in the slides. So I can ask
Yeah.
you questions, shower questions like as an examiner, okay, properly strict examiner. So then what you get is,
Yeah.
yes, that toughest only I have faced. So after that there is nothing. Okay, so that confidence also will come. Plus I'm going to give you answers anyway parallelly. Okay, so not only for you,
Right.
everybody who is preparing can always utilize this at a nominal fee so that it refines your exam skills. Okay, be it theory or practical. So that
Yes.
way, right?
Right. Yes, sir. That was great. Yes.
Yes.
It's like we can make mistakes here, at this level, yes. But when we are standing right there in front of the examiner, we will be much more polished. Yeah.
See, one thing I'll tell you, there is nobody who can be a tough examiner than, okay. So if
Absolutely.
Senthil sir has taken and he has told that it is like addressed means I don't think anybody can after that do, at least when it comes to the mainstream specialties like ortho, neuro, cardio. Okay. So even pediatrics or it can be women's health also. Okay. So to some extent. So definitely it should help and motivate the members that yes. So see, all about confidence only. One thing I'll tell you. If you are afraid, you speak
Yes.
truth also, it will look like it is a wrong answer. But if you are confident
Right.
and you are talking about an uncertain point also, everybody will feel that it must be correct. Okay. So that is the way it goes. And not all examiners are very competent enough with updated journal and knowledge and information and all the things. But at the same time, they want the student to be respecting them, to be learning from them. At the same time, the student should be open for all the options and opportunities. Okay, open-mindedness, not
Mhm.
too much of overconfidence, and not jumping into
Yeah.
conclusions. Okay, and having that decision-making
Right.
algorithm. Okay, yes, that I will do.
Yeah.
No means this I will check. If in that, if yes means that I will do. No means I will do that. First, initially improving, later not improving. Then I will check that. Then in that, if that is positive means I will do this, negative means I will do this. Okay, so everything they need that
Mhm.
decision making algorithm. Okay, so that
Right.
flexibility, that challenges why they pose. If the patient immediately improved, fully improved, what you will do? They will give suddenly. Okay, so how you are handling that unexpected challenges, how you are dynamically adapting to that situation. That is what is assessed there. Okay, in practicals. And
Right.
always be inquisitive to note down any point what is given, okay, by the examiners. And whenever they teach anything means immediately you tell that yes sir, yeah, this is something which I have to ensure that I take care. Correct. Note down.
Right.
Okay. It might look like buttering, but it is actually your real character. As Darshana, I know that it is real character. Okay. Don't be inhibited. Okay. Why I have to do that? Okay. So whether it will look kiddish. Okay. Don't think like that. Be honest to yourself
Mm.
and learn. Okay. So definitely you will enjoy the experience of giving the exam and performing. Okay.
Right, sir.
Right.
Yes. Thank you so much, sir.
So
Yes.
see you. Bye bye.
Bye bye.
We are ready to close the session. Ritu ma'am giving thanks and
Yes, sir.
good luck, madam. Yes, Uday Mala, good evening. Okay. So see you. Bye bye.
Yes.
And take care.
Thank you, sir.
Right. So we close the session. Yes.
Yes.